patient multiple failed bridges. Okay, all bridges are failed or failing. So if you see the frontal, the smile view is important. There is no gummy smile. This incisal position is reasonably good. In the ridge, okay, reasonably good. So whether alveoloplasty needed or not, we have to check. Okay. If there is good bone till at the crestal level, we may have to do some alveoloplasty. If there is recession, there is bone loss. Okay, there is no need to do alveoloplasty. Okay. So that is how we will determine whether alveoloplasty is needed or not. Because already the incisor position is correct, is a ridge position. So the same height of incisor we can do. So we will see the intraoral picture now, right idea. Okay. See, the bone is still here. The bone is okay till here because it's not a periodontitis case. There is no bone loss. So if you extract and if you place implants without doing alveoloplasty, then we may have difficulty in giving the process. Okay. So it is a kind of FP1. Here this canine is supra-erected. Okay, this canine. So we have to do mild alveoloplasty. It will, doing prosthetic step will become easier. The process also will be looking nice. So this is FP1. We will make it little FP2. Okay. And we will make it even also. Okay, here it is more, here it is down, here it is okay, it is in multiple position. And another reason to do alveoloplasty is the alveolar bone may be very weaker, maybe very thin. See, the labial bone is very thin. If you place implants without doing alveoloplasty, later after some time the bone will resolve because it is very thin. So that is also one reason better to do alveoloplasty. So doing alveoloplasty is to gain prosthetic space, to remove the weaker alveolar bone. The third reason is to gain even surface. Okay. So we did lower implant that day, right? We are doing for now. So this is the lower we did that day, right? This we removed after taking the implant, after taking the X-ray, right? So we placed this almost 7-8 implants. Okay, usually we place 6 implants, but here we did. It was because the bone was very porous. Okay, especially in the distal mandible. So we placed additional 2 implants. Okay. Now we are planning for the upper jaw. Okay, you can see the upper jaw. All bridges are failing. Recurrent decay below the bridges. Okay. This side will be. Now we will draw the arch form for maxilla. Okay. Before drawing arch form, check the axial view. Okay. So this is the sinus. Okay. We are coming from up. Okay. This is a nasolacrimal. So we are going from up to down. Okay. So this is the zygomatic bone. These are the concave. Okay, concave. Now we are coming to the maxillary alveolar. You can see the canal. You can see the labial concavity. So whenever there is a labial concavity, the situation becomes complicated. Okay. Now this is almost in the CEG. Okay, perform. See, here you can see the medial pterygoid, lateral pterygoid. So this is the tuberosity, this is the pterygoid. You can see the tuberosity is lateral, the pterygoid is medial. Okay. So the arch form goes like this and takes here, all turned here, right? You see, it is not a U-shaped bone. U, but the end of the U is slightly
Curved
curved
inside.
Very good. So when you are placing pterygoid implant, you have to observe this. So if you do drilling in this direction, you will go on to
Perforate.
touch the lateral pterygoid plate, which is not advisable. You have to go medially and catch this junction. Sorry, we are. Okay, so now we will draw the arch. The thing is here the left pterygoid, sorry, right pterygoid does not come up. In this, let's see. Yeah. Okay. Now we will see the cross section. First we will see the premolars. Right side we will do the planning first. This is the second premolar, right? So if you see the bone, about 80% of the length is porous till here. Only
Yes.
the apical end it is somewhat is okay. Okay. We will see the length. So almost you can place 14 to 15 mm of that. Okay. Now we will see if we tilt, we can get some good. Okay. Now we are tilting initially in the second premolar region. Even then the 50% of the bone is porous, but the apical end is somewhat is open. Okay, you can see the number is 1000. So tilting is another advantage. So if you place straight, bone quality is not that much great, but if you tilt slightly initially, you are getting good quality. So we can tilt and place. Okay. Internal. Okay. So we will be tilting this implant slightly. So when you tilt from the second premolar area, that means you cannot place implant in the first premolar area. Okay. So what we can do is we can place implant in the 1-1-2-1 region. Sorry, 1-1-2. Okay. We will see the bone quality in 1-1. You can see the labial plate is very thin. We will do some kind of plastic till here. Okay. So we will measure from here to here. Almost 16 mm is sufficient. Okay. We will see you can see the hourglass appearance here also. Okay. Here it becomes much. Bone is around 4.4, which is sufficient. Whether to place compressive or basal, both can be placed here. But if you place a basal, no, see the particle, it is around 2000 near the nasal floor. So if you place BCS, you will get more engagement from this area. So both reason you can place. So one implant at the 1-1. And another implant in the 1-2. So 1-2, the width becomes much lesser here. Okay. Because of the labial concavity, it is very, it's only 3.2 something. Okay. Here after doing a very fast, you can place. See here also the nasal floor is very
high.
Good cortical. Okay. You can see the values 1089. Here also you can place it distance. Okay. around 14 mm disease. Okay. So whether you can place the implant in the canine or not, we have to decide later. Because how much tilted we have done in the second premolar, it will decide. If you tilted very much, you cannot place implant in the canine. It will hit the implant, premolar implant. So we will keep this as the final option. If there is enough space, you can place the one implant in the canine or you can leave it. So totally 3 implants so far now. Okay. One implant in the second premolar and another 2 implants in the one molar. Definitely this is not enough. Okay. So we are seeing the sinus area. The bone is not very great. There is no bone actually. If you come closer to the 8 area, so this is the 8, just mesial to the 8, there is some bone is there. Just mesial to the root of 8, mesial root. Okay. You can place a good implant, wider implant also. This is also good. The is also it's around long 0.5. So 4.2 long 0.5 you can place excellent, and that will give a nice distal support to the process. Okay. Now we are planning for pterygoid. So adding pterygoid always increases the success rate because the pterygoid is a good bone. It distributes the forces, occlusion forces, magnetic forces. So distal root, along the distal root we can place. Along the just extract, uretic, along the distal root, we place a 16 mm implant, compressive also. So our okay. So this is the picture we need during surgery. So this will give an idea. Okay, we will plan this side also, then you can take picture. So if this picture is in the surgical room, in the view of the surgeon, we can correlate the planning and we can do. Okay, so totally 5 implants on the right side. Suppose if this, see the premolar implant, if this bone is excellent. Okay. Okay. There is no need to add 5th implant. Only 4 implant is enough. Only 8 implant is enough if this premolar implant is good. But here the bone quality is not good till 50%, right? Only here it is good. If the crestal bone is also good, if the entire bone is good, then we can reduce the number of implants. Okay, so the number of implants depends on the bone quality. Okay, here also the bone is not very great in the 1-1-2 area. It's very thin. You see the palatal surface of the tooth, it is close to the palatal bone. Usually the bone will come like this, there is enough good thickness, but here it is constricted. So now we are planning for, always plan the second premolar area first. Okay, so this is the second premolar. If you go straight, there is no bone. Actually this is a very different anatomy here. See the buccal plate, there is no buccal plate, or it's very thin. The apex is totally out. Okay. If you drill through the apex, what will happen? It will, even if you drill through the palatal apex, you may perforate. See the bone is coming like this and it takes a turn and comes like this. It is not going like this, or it is not going like this. So alveolar process in one direction. The tooth is in another direction. So drilling here is challenging. You may perforate labiously or you may perforate palatally. Okay. Going along the apex, along the long axis is not a good idea. So we will tilt and we will check. So tilting it is quite reasonable. Okay. Okay, the bone is around 300, 400, so 50 to 60 mm. So it is better to tilt in this side also. Actually, if you place implant in the first premolar region, tilting, the bone is excellent. Right? More than second premolar. See, this is the second premolar area. Tilting. Okay. See the bone quality now. But if we come in the premolar area, it is very good. Okay. The bone quality is also good. It is also good. The volume also is good. Okay. Now we can place one implant, premolar implant straight. Okay. And leave the second premolar and place one implant distal to the second premolar. Distal to the second premolar. Here also the bone is good actually. Okay. And the sinus floor is somewhat good. Around 14 mm length is there. So now we are avoiding the second premolar itself. Okay, we are placing one implant in the first premolar and in the medial part of the first molar. First molar. After that, the bone is not very good. You can try pterygoid, but it is not visible here. Or we can place one implant in the mesial root. Here this length is very less, right? So the bone continues. We can place the BCS here, extra additional support in the around 3.610 or 12. Sinus floor is good actually. Okay. There is some additional things, they are not important. Okay. We will see pterygoid. Possibly we will place pterygoid, otherwise we will place it. So one implant in the first premolar and another implant in the mesial appendice. Canine. Can you see the difficulty with this canine floor? The apex is very close to the nasal floor. There is no labial plate, or it is very thin. Definitely, if you place a compressive, there will be a bone resorption and exposure of the implant. Okay. That is a problem with canine. Canine is a long root, bulky root. If you remove, there is no bone left there to. You will get only socket. Okay. So we are avoiding canine here. Canine is the last option. 2-1. Okay. So there is no bone labially. Bulky also, bone loss, very thin, hourglass appearance. Labially there is concavity. So either you can place a thin implant compressive or you can place a basal. If basal, you will get good stability now, 2000 basal flow value. Okay. Both implant is now 2-2. 2-2 is much worse than 1-2. It's very thin. Okay. So we will try to place implant. So we will keep it as option. Okay. So comparatively, if you plan, the left side is more challenging. So if possible, you can place one implant in the canine also. So the implant will get engagement only from this basal part. There is no alveolar bone. There is a very less bone case there. Okay. So, since we are not tilting, you can place canine implant also. If you are tilting, you cannot place implant in the canine. So 2-1, 2-2, 2-3, 2-4, 2-5 we are leaving. 2-6 to some area, 2 implants. Pterygoid we will see during surgery. So almost it comes to 10 implants. Because of the poor quality of the bone, we are placing more number of implants. You can see the poor quality bone here. Right? There is no. This is the concavity we are talking about. The depression. The lower implants came well. You can see the big mental foramen. It's very unusual to see such kind of big mental foramen. Okay, that's it.